you'd said you'd practiced for, I don't know how many years, I'm sure a couple decades in the standard way, I suppose. You said you read Gary's book. I mean, how did that change what you're seeing in practice day to day? What can we expect for people that do the standard of care? I mean, standard of care is what we talk about. That's a legal standard. If you violate the standard of care, you may be liable for liability in a lawsuit. What is the standard of care? What are the results we typically see with that?
It was, once I learned, is that somebody comes in, the first thing you see is that they have hypertension or prediabetes, and you start talking to them about putting them on antihypertensive medication and maybe a metformin, and then you run the American Heart Association calculator and you say, oh, I think that you should be on a statin because your risk has crossed some certain threshold, whatever calculator you use. And when you start adding these meds, a lot of them promote insulin resistance. So they feed on themselves. Give somebody a diuretic and a statin, and they're going to need metformin. and then it can go runaway when you get a beta blocker in there. Not every beta blocker. And so they literally stack on each other, needing more med. And medications generally speaking, do not lead to a sense of well-being. They just give you good numbers, but they don't. Taking antihypertensive doesn't make you thrive. Yeah. I mean, the feeling is, guess who was taking blood pressure pills for 30 years? Yours truly. I got off the blood pressure pills when I changed my diet, not my weight. Just trying to empathize with I never thought I would be drug free. I mean, when I was cowboying, you get off your horse and run to open the gate to let, when the cattle are coming in, and it's like, I'm sluggish. That's when you're 24 years old. You feel like crap.
Can you ever remember, because, you obviously have been in medicine for a number of years now. Was there ever a point in medicine that you can remember where the reliance on drugs for every condition was not the case? I mean, do we have to go back 3 generations before we can think about when we actually thought about nutrition, or do we know that? I don't know. I don't remember it being that way.
Well, the nutrition feeds on itself generationally, I believe. I mean, that's a big subject, which is part of this subject. But when I was at Georgetown as a medical student, the old docs, gray hairs with white coats, had funds of knowledge about doing differential diagnosis, figuring out what's wrong with patients. And it wasn't all just metabolic syndrome. Now, 90% of it's metabolic syndrome. Back then, there was a lot to learn. Now it's like it's like if you haven't figured out where somebody sits on the metabolic disease scale, how can you take it any further? And you know what I'm saying is, like, if you have hyperinsulinemia, you got to get that calmed down before we can figure out what else is wrong with you.
Yeah, and I get, that's something that still even today, most physicians are unaware of what someone's insulin is, what their fasting insulin may be. It's kind of considered, why would I test for that type of thing? How do you, if you see your patients today, you mentioned, I think you said nursing homes and some other folks, how are you assessing them? Obviously you can you probably look at somebody and say, you got metabolic syndrome, probably just an eyeball test. But what do you do? What do you do when you work up and evaluate a patient?
First thing I check is a fasting insulin with, fasting glucose as being one of the key measures. And then you look at their lipid profile for signs of metabolic syndrome. And almost all of the time, you find it, and then trying to help people understand that you got to get rid of the sugar and starch to start tackling that. And one of the things I'm wondering about, and I've been doing more of, is taking people quickly to zero carb to get the effect. Mm-hmm. Because you can dance around, and I'm learning more about this all the time, is like, what if just you get too much glucose from your protein? If as protein's metabolized, you get a substantial amount of glucose. So if you start telling people, oh, you can have your salad too, well, maybe there's just that extra bit of carb in the salad doesn't work. And that might have worked for Dr. Adkins, but people are sicker now. It seems like it's a runaway. So it's like, maybe we should just get rid of all the carbs and get to the point, get you feeling better. And then we can just start discussing the broccoli, And I have a guy, unfortunately, he did that. He's crushing it. And then he comes in, his weight's up. And this is incidental. I'm glad this didn't happen early in my low carb toward carnivore career, is he went into AFib. That wasn't from the diet, I don't think. Mm-hmm. It's just, he was so close. I mean, 69-year-old guy with type 2 diabetes, totally not on meds, hasn't seen a doctor in years. It's like, wow, we can get a handle on this. And then, oh, dang it, you'd come in AFib with all sorts of edema in your legs. The point is that I'm hitting people harder, faster with trying to get them under control to see that they have control.
Yeah. Yeah. What, just out of curiosity, I know when I was practicing orthopedics, I was starting to think, well, maybe let me do some sort of, people come with like carpal tunnel syndrome. And I was like, I think this might be a manifestation of metabolic disease. And I would check their fasting insulin, and I guess not surprisingly, their fasting insulin was elevated with carpal tunnel syndrome, which most people would like, why the hell as an orthopedic surgeon are you checking fasting insulin? That was the first thing I got. I was like, why are you checking that? But are you seeing a relationship between high fasting insulin and other conditions outside of just, say, diabetes and things like that? Are you seeing like arthritis or, I don't know, mental health issues? What do you see it associated with?
Definitely. Just funny on the carpal tunnel, when I show people a cross-section of the carpal tunnel, it's like, well, what can you fix in the carpal tunnel by diet? There's structural fat in there that needs to be there, but what if that shrunk by 3%? Get it? Or what if you have a tiny bit of edema and because what's the great diuretic is lower your insulin. Well, that can take away your carpal tunnel. Mm-hmm. And you'll like this, Shawn. I've only connected with this in the past week or two. Is my hobby is just this trying to explain to ranchers. I say, you have metabolic syndrome, and founder is a lay term for equine metabolic syndrome. The interesting thing is, for those who don't know, founder, one of the primary manifestations that makes a horse go lame by damaging the blood vessels in the hooves, and then they go lame. And the typical thing is that the horse has to be put down unless it's a really special horse and you feed it back to health. So the connection I wondered about in humans, it seems like we're so slow to founder, but maybe not. Maybe our aches and pains and the cartilage damage is actually something to do with poor vascular supply because of hyperinsulinemia. And because we've all heard my joints quit aching when I lost 3 pounds out of my 350 pounds. Mm-hmm. It's not weight loss. It's metabolism, right? It's got to be. So I'm starting to see even more connections. And the funniest thing is that if you were a veterinarian to the rich and famous horse, their paradigm is exactly the same as mine. What's your insulin level? And in horses, it's get rid of the non-fiber carbohydrates and they recover. In my patients, it's non-fiber carbohydrates. And then why have the fiber when it's just going to bloat you and make you pass gas? So it's really funny that if you're a horse in England, you're better off than any of Dr. Unwin's patients as far as your lab access. Well, because you could get an insulin level on a horse there